U.S. Surgeon General, the CDC, and the vast majority of clinical, public health, and commercial tobacco control organizations that work in this field have flagged the striking use of tobacco products by individuals with mental health or substance use challenges as a significant health disparities issue. As a result of tobacco use, the behavioral health population suffers a disproportionate amount of tobacco-related illness, including cancer, lung disease, heart disease, and other health disorders. What we're going to be looking at today are ways that behavioral health providers can treat tobacco use among their clients, as well as a few disturbing trends about tobacco use in this population. I need to point out that this webinar is hosted by the Public Health Law Center, a national nonprofit network of legal centers, attorneys, and policy analysts that support public health and commercial tobacco control policy change at the state, local, tribal, and national levels. We're located in St. Paul, Minnesota, in the indigenous homelands of the Dakota people, also known as the Sioux Nation. This region is also shared territory with the Anishinaabe, also known as the Ojibwa or Chippewa. We support public health by providing free legal technical assistance to public health advocates and professionals around the United States in several ways through legal research, policy development, implementation, and defense, a wealth of publications, all of which are on our website, publichealthlawcenter.org. And we also do presentations and webinars, such as this one. We don't represent clients in court, and we don't lobby. Finally, our organization is committed to the principle that good public health cannot be achieved without addressing health equity. So our key speaker today is Dr. Jill Williams, professor of psychiatry and director of the Division of Addiction Psychiatry at Rutgers Robert Wood Johnson Medical School in New Brunswick. She also holds a faculty appointment at the Cancer Institute of New Jersey. Dr. Williams is one of the nation's leading experts on nicotine dependency treatment for individuals with mental health and substance use disorders and psychiatric comorbidity. She's not only a respected physician, she's a noted researcher who keeps up on the latest studies in this area, including those related to the use of medical and adult cannabis use and tobacco, and the impact of these products on behavioral health. She's a sought-after trainer and public speaker, and we're thrilled that she'll be presenting on this topic today. Before I turn the podium over to Dr. Williams, I want to point out that our public health organization works with states, local communities, and clinical providers across the U.S., as well as policymakers and public health professionals, to address the use of commercial tobacco use, particularly as it affects the most susceptible members of our community. Evidence-based laws and policies at the state and local level can significantly impact tobacco use in the behavioral health population, particularly the way in which tobacco products are marketed and targeted to certain populations and the way they're priced and sold. Other effective policies include restrictions on retail licensing and sales of certain popular products, such as flavored products, particularly to youth. States and local communities can enact comprehensive smoke-free and tobacco-free laws and policies. They can work to make tobacco cessation resources and treatment affordable, and they can promote tobacco cessation in mass media campaigns, require pictorial health warnings on tobacco and nicotine products, and fund and maintain comprehensive statewide tobacco control programs. Of course, along with state and local communities, mental health and substance use treatment facilities can play a key role in helping to reduce tobacco use and dependency in the behavioral health population. For example, providers can ensure that clients are treated in a tobacco-free setting by adopting tobacco-free or smoke-free policies, and they can ensure that clients get the cessation support they need by integrating treatment into clinical care. So here are just a few of the resources on our center's website with recommended policies and approaches for providers to consider. With that, then I'm going to turn the podium over to Dr. Williams, who will be discussing in more detail the critical impact of tobacco use on individuals with mental health and substance use issues and what providers can do to help clients with these challenges. Dr. Williams.
Thank you. Thank you so much for inviting me to be here today, Carrie. And I really am a big fan of the Public Health Law Center, so I appreciate this very much, the opportunity to speak to your group. I'm going to be, as Carrie mentioned, talking about some of the newer trends in terms of patterns that we are seeing emerging with this issue of tobacco and behavioral health populations. Let me start with the most recent Surgeon General's report on smoking cessation that I imagine many of you are familiar with, came out in 2020 and really was striking. I've been working in this area of tobacco and behavioral health now for 20 years. So this was quite significant that really for the first time, a Surgeon General's report acknowledged this issue, that in fact, smoking is much more common in individuals with mental illness than in other adults. So this was an important, for many reasons, that this appeared in the Surgeon General's report. And it's measuring mental illness here, of course, with this proxy measurement called serious psychological distress, which you can see smoking rates are always higher in populations who identify recent serious psychological distress, which is complicated, of course, by other measurements associated with higher tobacco use rates, lower socioeconomic status. So also in combination with poverty and lower education, we see really the highest tobacco use rates. And I won't really spend a lot of time on this, again, because I imagine you're quite familiar with this, but of course, these populations suffer many of the same health consequences, major health consequences related to tobacco use. It's the #1 cause of death in the behavioral health population, similar to the general population, with huge numbers for heart disease, lung disease, cancer, where it's a huge contributor to morbidity and mortality, as well as contributing to other diseases. And we see now even the emergence of COVID and the role that tobacco plays in increasing the severity of COVID illness, which again has impacted this population as well. Interestingly, when we're working with these populations and doing counseling, specifically, it sometimes is actually helpful to emphasize the other consequences of tobacco. Sometimes they're more relevant to individuals who may be struggling on a day-to-day basis and not as tuned in to some of the health consequences. So we talk about really how it affects you on a daily basis, how tobacco is affecting you today, how it can really be a barrier to living successfully in the community and to your mental health recovery because of the financial hardships of being a tobacco user, making it harder to obtain and keep a job, harder to succeed in public housing. We know now there's so much evidence that tobacco is associated with worse mental health. It's not the medication that people used to speak of 20 years ago. A compelling evidence that tobacco users have a greater rates of suicide, more relapse back to drugs and alcohol if they're trying to achieve abstinence. There's also the stigma of being a smoker nowadays. It contributes to wrinkles and worse appearance, and it's still the #1 cause of fatal house fire. So sometimes talking about some of these more urgent issues for people, maybe things that are more relevant to them in their day-to-day life, can be helpful in terms of trying to increase motivation to change. So let me just emphasize some of the behavioral health outcomes specifically. As I mentioned, we now have a tremendous evidence that tobacco use is actually associated with worse behavioral health outcomes. Really, the sickest patients are the ones who struggle with the highest rates of tobacco use. So from many epidemiologic and clinical studies, we know that people that use tobacco tend to have more serious symptoms, whether the illness is depression or schizophrenia, bipolar disorder, or anxiety. That trend is true, that people seem to have worse symptoms if they are also users of tobacco. We know that in young people who use tobacco, It's a marker of an earlier onset and a worse prognosis in terms of subsequent development of behavioral health conditions. So we know that in young people, tobacco leads to mental illness, and we also know that young people with mental illness tend to use more tobacco. So it's sort of bidirectional and worse in both ways. As I mentioned, there's now really overwhelming evidence that tobacco use is associated with suicide. This is just the most recent review and meta-analysis of more than 8,000 individuals, where current smokers clearly had higher risk compared to non-smokers of suicidal ideation, making suicide plans, making suicide attempts, and dying of suicide. And you see the odds ratio there is 2 to 3 times higher. So that this is really conclusive at this point based on more than a decade of evidence. And finally, as I mentioned, for substance use populations specifically, working on abstinence from their primary substance use disorder, using tobacco will really interfere with that and contribute to more relapses back to drugs and alcohol. Again, this was a very nice meta-analysis that looked at the impact of quitting smoking on mental health, where the evidence again was overwhelming that in the 6 weeks to 6 months after somebody quits smoking, that there's really overwhelming evidence that anxiety goes down, depression goes down, stress goes down, quality of life and mood are essentially improved. So again, not only is tobacco use associated with worse mental health, but quitting, in fact, seems to help people to recover and contribute to, in fact, better mental health. Unfortunately, even though we've made advances in the behavioral health community in terms of addressing tobacco, we're still not doing enough. And even recent studies, surveys, epidemiologic studies show that there are still considerable barriers to addressing people's tobacco use in the behavioral health setting, sort of holding on to these old beliefs about culture, buy-in, that this is really not a priority in behavioral health settings. So unfortunately, it still remains low. We know smoking used to be used as a reward or incentive. Hopefully that's much less nowadays, but still sort of seen as an acceptable shared activity among individuals. Still some of these old ideas that treating tobacco is not within the scope of practice for somebody in behavioral health. And still evidence that psychiatrists and other behavioral health providers are doing less than other US healthcare workers. And again, staff shortages in behavioral health probably make this worse and more challenging in terms of lowering it further on the priority scale. So fairly recent data, this was a survey conducted by the CDC, really confirms what I'm saying, that access to tobacco treatment in behavioral settings is still pretty poor in this country universally. This was looking at all 50 states and broken down by either mental health treatment facilities or substance abuse treatment facilities. And you can see the rates of screening for tobacco across these sites. This is sort of the average for the 50 states. And then the rates of actually doing tobacco intervention. And sadly, screening or even asking about tobacco use isn't even done half the time in mental health treatment facilities, which is frankly pretty shocking, you know, even as of 2016, that we don't even ask about tobacco half the time in these facilities. And as you can imagine, if you don't even ask about tobacco, the rates of intervention are going to be lower still. And that's what we see on this slide. And we see that they're similarly low in substance abuse treatment facilities across the country. And this is just to point out that mental illness is not a rare condition, right? It affects 20 to 40% of the population in terms of lifetime prevalence. And that's something like 36 million people with a mental illness and an additional 12 million with a substance use disorder. Then there's a significant overlap even in that group of what we call co-occurring disorders, people that experience both mental illness and substance use disorders. So these are affecting huge portions of the population, which can help us really understand how tobacco use among this group can be really a considerable piece of sort of who's left using tobacco in this country today, and that the issues are quite complex, and that this crosses over into other sort of disparity or subpopulation groups. Just briefly, kind of to put this into context again with recent trends, there's still more than 10 million people in the United States who misuse opioids. We're still in the midst of an opioid crisis. And although we often hear about overdose deaths, which are tragic, of course, in young people, overdose deaths from fentanyl and heroin. In fact, when you look at total opioid misuse, it's still predominantly a pill problem, that 97% of all the opioid misuse in this country is still primarily people misusing prescription pain pills. And so although the rates of pain pill misuse are decreasing from what they were a few years ago, they're still significant at more than 10 million people. And, when you look at the kind of prototypical person in this country who's using prescription opioids, we know that it's people with a mental illness. So again, sort of the prototypical person using prescription opioids based on some of this data is an individual with poor physical health, poor mental health. They tend to be young, obese, uninsured, smokers, more often white populations, and more females than males in terms of prescription opioid use. So you can see how these get in kind of complex in terms of the numerous issues that these people are struggling with in addition to tobacco use. And tobacco really crosses all of these categories. So although tobacco use continues to decline, a bit of good news, at least in terms of cigarette use in this country, we know that that continues to track down every year, even still in recent years, that sort of the opposite effect we're seeing with cannabis. So while tobacco is going down, unfortunately, cannabis use is increasing in this country. And so I think it's interesting to sort of consider them simultaneously. And of course, it's not completely fair to say that all tobacco use is going down. Cigarette use clearly is going down, but we know that e-cigarette use is still quite high, quite problematic, and especially in young populations really is the dominant form that is used. So I'm just going to talk briefly about some of these ideas, just to introduce some of this idea about considering cannabis with tobacco, again, to consider trends and changing use patterns and the need for surveillance. So as things are changing, and even defining these products gets quite challenging in understanding what people are using. Are they using combustible products, or are they vaping nicotine and cannabis through other devices? So delivery is interesting. Again, the combustible aspect. This is further complicated by the landscape, the rapidly changing landscape of legalization and medical cannabis use. So this gets quite complex to think about all the unique aspects of this issue. There's sort of emerging evidence that if you use both cannabis and tobacco, you tend to have worse mental health, worse physical health, compared with if you use only one or the other. If you use both, it impacts your ability to quit tobacco and seems to make you less likely to quit tobacco. It also seems to make you less likely to quit cannabis. And then there's sort of unique population issues like pregnant women and how there may be unique consequences or impact in those groups. And of course, this is a group interested in policy and public health, of which the implications are vast. And I'm sure you all know more about this than I do. But really, how is this going to impact our regulations on clean indoor air and public spaces, as well as issues with the industries, taxation, and sort of these changing patterns? I'll be the first to say that, I'm not going to say in my talk today that all cannabis is bad. That's not the point of my talk. When we understand people having more problematic cannabis use, it does seem to be linked to to daily cannabis use. So daily cannabis use is a good proxy measurement for cannabis problems and for further consequences related to cannabis use. So if we look at the increase in daily cannabis users in this country in the last decade, you can see that it's almost entirely in people who smoke cigarettes. That again, daily cannabis use has increased most dramatically among smoking populations. This is just cannabis use trends in a little bit more detail, where you can see tracking up every year from 2016 to 2019 in really every age group. Looking at this in different ways. The top graph is showing just past month marijuana use. You can see the dramatic increase, especially in 26 and older populations. But not only is there an increase in use of cannabis in this country, but also increases in cannabis use disorder. So the substance use disorder or the addiction associated with cannabis. And you can see that that's gone up particularly rapidly in the 12 to 17-year-old group. When people discuss the risk for addiction from cannabis, certainly you can get addicted from cannabis. They would cite a number of about 9% risk for addiction in all users. But in any ways, that's a misleading number, because in fact, the rate of developing an addiction to cannabis is double that if you start in your teens, which is typically when most users do start their use. And it goes up to 25 to 50% if in fact you're a daily user with a young or teenage onset. So the risk is actually quite high, much higher than 9%. And again, this is further complicated, as I mentioned, by subpopulations that may only vape versus use combustible products. And the trends may be different in these different subgroups. So 1 out of 10 high school students reported ever vaping cannabis. And they may even be doing this through their e-cigarette device. And adolescents have a higher rate of vaping cannabis if they've ever used cigars, water pipe, and not surprisingly, e-cigarettes. In this analysis, smoking combustible cigarettes did not have an association, but the other tobacco products did carry a higher risk for a vaping of cannabis. And again, pointing out again, the numerous complexities here, even in terms of understanding specific products that people are using, delivery, the definition of these products, the rapidly changing landscape. So a spliff, for example, is tobacco that's rolled in with marijuana, whereas a blunt is a slightly different product where the cannabis is actually wrapped in tobacco leaf. Again, people may be using more vaporizers, non-combustible forms. They may be using concurrently both products. They may be using them sequentially, and they may literally be using them mixed in the exact same product. So again, a lot of changes here. And as I mentioned, the landscape of legalization, medical cannabis, and even people talking about decriminalization kind of further complicates this. And again, then begins to really overlap significantly into the policy sphere. Legal and people tend to lump some of these issues together where really they're quite distinct and different. So I just wanted to define them to make sure we're all sort of speaking the same language. A legalization of marijuana for recreational use, may be an issue that the voters decide on. The way that we have developed medical cannabis in this country has been through similar processes of voting, legislators, governors' decisions, which is quite different than the way we develop any other medication, which is based on FDA approval, randomized clinical trials. And so keep in mind that medical cannabis has sort of circumvented that usual process and not followed sort of any of those rules in terms of how we think about medication safety and efficacy and delivering that to the public. I don't think anybody really would argue with decriminalization nowadays because there's significant evidence of racial and other discrimination. For example, African Americans are arrested for marijuana possession at 4 times higher rates than whites. They often suffer longer and harsher sentences despite really equivalent patterns of use across the racial subgroups. New York has sort of a standard for decriminalization law that people say is quite good, where you can publicly possess marijuana without criminal penalties. You can get your records expunged, but you can still be arrested for intent to sell and distribute. So again, these are all sort of slightly different issues, and it's important to sort of understand what we're talking about. And related to all of this as well is sort of the federal DEA definition of cannabis as a Schedule I substance. Schedule I implies that there is no accepted medical use, and many people also support that cannabis be changed from its Schedule I status, because one of the issues is that Schedule I really restricts access highly and doesn't allow for much medical research to occur. So these are sort of all the issues sort of complicating the cannabis landscape. And now that we've had legalization in several states for some time, people are really trying to tease out the impact of legalization, and there's still a lot that we don't know. There's many uncertainties. We do know for sure that legalization results in increased use in the population. There's no question that use goes up as a result of legalization. The data is somewhat mixed in terms of evidence for more car crash fatalities and injuries. People suspect that that's going to be true, but that has not yet been proven. There is evidence of more emergency room presentations related to cannabis as a result of legalization, as well as more people having addiction and presenting for addiction treatment. And again, relevant to our discussion here, legalization may really threaten clean indoor air norms. It may renormalize smoking in public places where smoking has been otherwise forbidden. An example of that is that Airbnb listings in Colorado often permit the use of cannabis inside the property, and of these, 30% also allow tobacco smoking. So sort of a loosening of sort of accepted practice and clean indoor air laws as a result of changing views on cannabis. This is just a snapshot again of data from Colorado, again, trying to tease out the impact of legalization, showing some of the things I already mentioned, that in Colorado compared to the rest of the country, you see higher rates for past month marijuana use, as well as higher daily marijuana use. You know, concerningly, perhaps that's also in the 18 to 25 year group, as well as the over 26. Interestingly, again, some data in Colorado suggesting higher rates overall for substance use disorder and co-occurring substance use and mental illness. This is association data, of course, cannot establish causality, but interesting to consider why would Colorado have higher rates of mental illness than other parts of the country. And somewhat suspicious for the potential role of cannabis. Just brief comments about medical marijuana. Some of this is my opinion. A lot of this is also shared by other medical professionals, though, that really the terminology for medical marijuana is really a bad concept. It's bad language. The idea that someone can go home and smoke their medicine is sort of seems like a flawed idea for me, given what we know about smoke. Smoke is still bad and contains many of the toxins similar to cigarette smoke. When you go home and use cannabis, it's often not standardized in dose. The potency may vary, the chemical makeup of the strain, the route of administration can vary. So exact dosing is not really at all happening. And so that's a reason for concern. But certainly it may be true, and it already seems to be true, that cannabis will contain medicinal compounds that will be of great therapeutic value. And I think that that's sort of where we're headed, although the idea that that we're really using this plant as medicine, may be a flawed idea. because when you think about what's in cannabis, right, it's not one thing. There's at least 400 different components because it's a highly complex plant. At least 80 of those chemicals belong to the family of cannabinoids. Delta-9 THC, of course, is the one that's psychoactive, that gives you the high associated with cannabis use, but there's lots of other cannabinoids in the plant. CBD is one of great interest in terms of its potential medicinal value. We now know that other cannabinoids like Delta-8 THC also possess some psychoactive properties and are becoming increasingly available in the market. But this idea that, smoke is still going to be toxic. And in a state like New Jersey, for example, in the medical marijuana program, for a long time, the only product that was available was basically a bud of a plant that you would go home and smoke. And smoke is toxic and still produces carbon monoxide and other dangerous chemicals. And that's cause for concern. In terms of the evidence for medical cannabis, again, it's fairly mixed. It's not conclusive by any means. There's only moderate quality evidence that medical cannabis helps chronic pain. It does seem to help some severe neurological conditions that include severe muscle spasticity. There's actually low quality evidence that cannabis even helps for nausea, vomiting, severe weight loss. And of course, you always have to balance that out with the risk for adverse events. I'm a psychiatrist, and there's actually no compelling evidence that medical cannabis is helpful for psychiatric disorders. You could argue that the studies are limited, but at this point, there's really no evidence that it's helpful. And we have to balance that absence of evidence with the risk for addiction, withdrawal, the considerable risk for psychosis that people can develop from cannabis use, the impact on cognition, memory, IQ, driving ability. So at this point, there's really no strong evidence for psychiatric disorders. Again, back to CBD, one component of cannabis. There is very interesting research supporting that CBD itself may be helpful and may be a possible future therapeutic, which reduces anxiety and also helps schizophrenia. It's a little early to say, but there is some promising research in that area. I've been in the field of tobacco now for a long time, and I remember that even when we talked about the possibility that nicotine might have a beneficial, although modest, effect on mood and cognition, especially in illnesses like schizophrenia, that this really wasn't a rationale for smoking, that it didn't outweigh all the toxicities that come from cigarette smoke. And in a lot of ways, it feels to me like deja vu for the smoking medication hypothesis. We just don't have the evidence to support this usefulness at this time. I would be the first to say that there are no issues in terms of thinking about medical cannabis in a palliative way, people who are end of life, if it reduces suffering. Certainly I wouldn't have any problem with that. And again, that there is some evidence that it can be helpful for severe neurological or debilitating issues of spasticity, diseases like multiple sclerosis. I guess what I'm seeing though as a clinician is a lot of anxious college kids using medical cannabis. And I don't think that was really anyone's intent, but I think that's where we're headed. And I see that as an enormous problem looming in our future. It's quite easy to go online and get approved for your medical cannabis. And this is available really in all states, especially with telemedicine. It's probably gotten easier that you can go online to talk to your medical marijuana doctor and you'll get approved or your money back, which is not usually the way we promote medical treatments. And so clearly the idea that this is medicine has sort of jumped the tracks. Other concerns related to cannabis include the potency of the THC, or the psychoactive part, which we know has greatly increased since the 1990s, when cannabis used to contain about 4% THC. It now typically it can be up to about 25% THC. And the potency is one of the clear risk factors that helps us underscore adverse effects from cannabis use. So the higher the potency of the THC, the more likely people are to suffer more consequences, whether that's addiction or the development of psychosis. We know that people aren't even using the plant necessarily nowadays, that there are sophisticated extracts, oils, and other formulations that can be as high as 80% THC. Again, increase in THC since the 1990s has been related to the increase in treatment admissions for cannabis use disorder. So the greatest risks we can associate with cannabis use include the age of onset. So the younger somebody starts, the more likely they are to have a worse outcome. The frequency of use, so daily use, carries the greatest risk, as well as the potency of the THC in the product. Delta 8 THC we're hearing a lot about, as well as newer cannabinoids. These are produced from hemp, so technically they're not illegal, although this one is a mild psychoactive, so not felt to be as strong as Delta 9 THC, but still psychoactive, and now widely available. It has a long shelf life, so it's sort of preferred in terms of making these honey sticks or other sort of candy kind of formulations, edibles that are widely available. And childhood poisonings related to Delta 8 THC are also rising. So this is not illegal anywhere at this point. And of course, this is really when we think about these issues, the greatest impact, the greatest risk, of course, is in young people. We know that young people are really experimenting with alcohol, tobacco, and cannabis at around the same time, that's the greatest time for risk and exposure. There's now evidence that you may know that use of electronic cigarettes is strongly associated with subsequent use of combustible tobacco cigarettes in youth, and that even low-risk youth that you would predict would be unlikely to smoke cigarettes, are now smoking cigarettes as a result of their earlier e-cigarette use. So the concern over youth uptake is really one of the primary issues I feel around e-cigarette use. It's still sort of considered controversial in this country if we should be promoting them as a cessation tool for perhaps an older smoker who hasn't been able to quit with traditional means. We can say that they're safer than a cigarette because of the lack of carbon monoxide and other products of combustion, but of course that doesn't necessarily mean that these products are safe, and they carry their own set of risks. They're not regulated, and there's a lot of variation between products. And I think people are really increasingly thinking about this sort of issue of continuum of risk, where something like nicotine replacement medication carries the lowest risk for tobacco users. Cigarettes carry the highest risk, and e-cigarettes are somewhere in between. In terms of helping people to quit them who become addicted to e-cigarettes, not much is known. Really, studies haven't been published yet, although it's nicotine addiction essentially, so presumably the same treatments will work and can be used, but we really don't have much evidence to support that at this time. And as I mentioned, now we're really emerging into this new area where there's this vaping culture and this sort of continuity where people are using multiple products and maybe even using them together. And we don't yet know the full impact of what that's going to mean. In contrast to the US, we know that the UK has been fairly supportive in terms of the use of e-cigarettes for smokers to use it as a cessation aid. They've really promoted this as a public health strategy. Sort of the philosophy coming out of the UK is that these are really popular products. People like them and are willing to use them. And assuming that they work as well as the patch, we'll be able to reach more people through them. And it also causes no cost to the healthcare system if people are using them as a way to quit smoking. There's now been several studies that have emerged, which at least support some use of e-cigarettes as a cessation aid. I don't think it's conclusive yet, but I think the evidence is growing in this area. This was really one of the first studies to show, a large study, using a refillable e-cigarette or randomized to combination NRT, which is a good control group comparison. These were people who wanted to try to quit smoking, who also participated in counseling, and the e-cigarette success rates, were comparable or slightly higher than the nicotine replacement. Although you might think it's a problem that a year out, they were still using their e-cigarette, compared with very low rates of NRT at that time, which really does suggest that people are replacing their nicotine addiction with this alternative product, and they continue to use it perhaps long term. That may bring a whole new set of problems, but the risk overall in terms of health exposure to carbon monoxide and other toxins would clearly be less, even in this scenario. Some other new trials have emerged. This one out of New Zealand, again, a fairly large study. This one had limited counseling support in combination. So you were randomized to either nicotine patch and e-cigarette, or nicotine patch and an e-cigarette that was essentially a placebo. It didn't contain any nicotine. And the highest success rates for quitting were seen in the group that received both patch and e-cigarette. So increased your chances of quitting by 1.5 to 2 times. This one was just very recently published. It was a population study looking at people over time, more of an epidemiologic study. 1,600 smokers who were not intending to quit, their data was followed over a 5-year period. Interestingly, in these smokers, they were a fairly high smoking group. More than half of them smoked, or half of them smoked more than 20 cigarettes a day. So that's a heavy smoking group nowadays, not intending to quit. And then if you just look at what happened to their natural quit history over 5 years, about 6% quit smoking and 11% don't quit, although they're able to reduce their smoking significantly such that they're no longer daily smokers. But if you look at the group that used e-cigarettes daily, you see that the quit rate jumps to 28% quit if they switched from daily smoking to daily e-cigarette, which is an 8 times greater quit rate. Again, the group that went from daily smoking to daily e-cigarettes but didn't quit also had a 46%. 46% of them quit daily smoking by using an e-cigarette, although they didn't quit completely. They quit daily smoking. And interestingly, just using your e-cigarette occasionally didn't have an impact on quitting. So these really were people who switched products. They switched from cigarettes to daily e-cigarette, and they seem to have some significant gains in this data analysis. Of course, we have to balance this with the risks, which are real, and perhaps related in this country a bit to the lack of regulation of products. I think that's a factor here, but the risk that we see that people have experienced in terms of EVALI, a significant lung injury related to the use of these products, related to contaminants. Again, most of these cases were linked to THC devices, although there were a percentage of people who reported vaping nicotine alone who developed this kind of lung injury. So again, safer than a cigarette, but we cannot say that they are safe completely. As I mentioned, when people are co-users and really using both concurrently, that there's evidence that they do worse in terms of having more psychiatric problems, more health problems, greater risk for substance use disorder of either one, so greater risk for addiction, more difficulty quitting these substances. Interestingly, when people use both, they often rate that they would be interested in quitting tobacco. They're less likely to report that they want to quit cannabis, so the motivations may differ between the products. People do seem to engage in some kinds of drug substitution, where if they're wanting to quit one, they may use the other one more heavily. We don't really know best treatment strategies at this point for someone like this, although it seems intuitively that it will be important to address these issues kind of concurrently and in an integrated way to give people the best chances of success. But we don't really know what interventions are going to be helpful in terms of targeting both behaviors. Just a consideration for pregnancy. In this country, we know that still about 7% of women smoke during pregnancy, about 2% use e-cigarettes, and that this has been fairly constant over time. There hasn't been tremendous changes or gains in that statistic over time, or at least since 2005. Conversely, cannabis use has doubled in that same time period. 4 to 5% of pregnant women will report using cannabis use during their pregnancy. But if you look at the group who smoke cigarettes, it goes up to 21%. So 21% use prenatal cannabis if they also were smoking cigarettes. So we see the impact of the co-use on having worse outcomes and probably interfering with cessation and other efforts. High frequency use of cannabis during pregnancy is clearly a risk that contributes to negative outcomes, including low birth weight. So again, considerations for treatment. The motivation for the different substances may differ. People may be motivated for one or the other. It has implications for how people experience withdrawal symptoms and the severity of that withdrawal. If you're using one, you may be more vulnerable to craving and relapse. So they're really going to influence the use of the other. And, if people are switching, if people say, well, I'm going to quit tobacco, and so I'm going to use more cannabis to help me to quit tobacco, we generally don't think that that's a great idea, just sort of drug switching, because you're still using the same behavior. You're still doing smoking behavior. You're still using drugs to cope. Smoke is, of course, still bad and toxic to your body. And the continued use of cannabis may cause you to have more craving for tobacco and therefore interfere with your cessation attempt. So there's really complicated and numerous considerations for treatment and how this is going to affect treatment. There's been very few studies looking at sort of strategies for managing both of these. The studies that have been done mostly in men. And then this is going to be further complicated if people have depression or other kinds of mental health comorbidity. This was just a small but interesting survey about attitudes in co-users. Again, in this survey, people report a high interest in wanting to quit tobacco, but a very low interest in thinking about quitting their cannabis, similar to their sort of past behaviors. Many of them had tried to quit smoking, fewer of them had tried to quit cannabis. And they report that they use more cannabis while they're trying to quit smoking. And the opposite is also true. So maybe in our smoking studies and clinics, we're not always considering this as an important covariate, something that's really impacting people's outcome. They may not be comfortable always talking about this, but I think it's something we need to explore and try to understand better in the future. I think it's interesting to look at the different withdrawal syndromes for cannabis and tobacco to point out the huge overlap in non-specific sort of irritation, irritability, insomnia, bad mood, restlessness that can occur with both, pointing out really the challenge then of knowing that we're sort of treating people's tobacco withdrawal adequately, understanding each how they may contribute or how to optimize the use of pharmacotherapy. So I think that's sort of an interesting factor that we just don't know a lot about. But we certainly know that when people use cannabis, they seem less likely to quit smoking. And in this analysis, looking at quit ratio, so your likelihood essentially over time of becoming a former smoker, we know that if you use cannabis, your quit ratio is less than populations that don't use cannabis. And it's really the lowest if you have cannabis use disorder. So if you're at the point where you're using enough cannabis that you're having a problem with it or an addiction, again, those people seem to have the lowest quit ratio or likelihood of becoming a former smoker. Another interesting angle to all of this, and again, I'm sure you all know and think about this more than I do, is just thinking about the industry and the overlap of the industries and the whole area of thinking about marketing. And you know, before there was Juul, there was PAX, which developed a cannabis vaping device, which of course is identical to Juul. And so the industry is going to may increasingly overlap, and that's going to be a challenge in terms of regulation. There's all kinds of impacts, as I mentioned, on tax, sales, policy, advertising. The list kind of goes on and on. So I didn't answer a lot of questions. I think I raised more questions today than I answered, but I think it points out sort of the need for greater surveillance and consideration of these complicated issues. Certainly, we continue to need more attention to addressing tobacco generally in our behavioral health settings. There's still a lot more we need to do, but I think this emerging factor sort of should be considered, well, especially when we think about the negative impact of co-use, again, on people's mental health, physical health, their ability to quit tobacco, their ability to quit cannabis, and then the impact in special populations like pregnant women. Opens a huge can of worms for policy and public health implications. I'm sure you'll have a lot of really interesting comments and questions. And so I will leave it at that and turn it back to Carrie.
Thank you so much, Dr. Williams. That was fascinating. So much information. We've gotten a few questions, and please, I want to encourage folks to submit questions. We still have several minutes to go, and I know Dr. Williams will be more than happy to answer your questions and respond to your comments. I do want to mention that this webinar we have applied for CLE credit for this webinar for those of you who are attorneys. Okay, I have a question here. How can we get clinicians who use tobacco to buy into assessment and providing treatment and or referral?
I think that's a great question and certainly really relevant for behavioral health treatment settings. There's been some evidence that perhaps the staff that work in those settings use tobacco at higher rates than other healthcare professionals. We could understand that would make sense. We would almost expect that when we understand that we employ so many peers or people who have lived experience in the field. It's sort of a tradition and a part of what we do. So it's almost expected that we would have many people who work in our settings who may have higher tobacco use rates. And so I think part of a successful initiative at a program or an agency, or even any kind of policy initiative or treatment initiative for that matter, really has to be inclusive and think about this idea about staff smoking. We want to do it in a way that's not perceived as punitive, as a way that's sort of helpful with a message of we care about everyone's tobacco, including the staff, so that we can get people on board and reduce some of the resistance. I think it's better than it used to be, and there's generally more buy-in for this issue. I generally recommend that if somebody is still using tobacco, that they not sort of lead, tobacco treatment group or other sorts of services, because that's sort of a principle of addiction that a person really should be in recovery themselves before they're offering treatment to others. But I think that including tobacco users in your work group or in the plan or in the policy development is really important in getting buy-in from people and having them feel like part of the process that they can contribute to and hopefully help them to become more motivated in working on their own tobacco.
Thank you. We had another question, and this had to do with the potential policy that the FDA is considering to reduce nicotine in cigarettes and possibly other combusted tobacco products to minimally addictive levels. And just before we turn it over to Dr. Williams, it's important to understand the FDA really at this point hasn't taken any steps toward proposing a new policy reducing nicotine. They did issue an advance notice of proposed rulemaking in 2018 on a tobacco product standard for nicotine level of combusted cigarettes, but and solicited public comments. But at this point, they've remained silent. So, Jill, I was wondering if you had any thoughts on how if there was such a policy, it would impact this population, or what research might be needed on this issue.
Yeah, it's such an interesting question. And the FDA, sort of in anticipation of it, of its consideration, did pay for support some of the research in this area that's now been published. So some studies were conducted of individuals with schizophrenia and other serious mental illness to look at the impact of using these very low nicotine cigarettes in these populations. And the studies were mostly promising in the sense that they were well tolerated by these populations. There's no evidence their mental illness got any worse. They also didn't engage in a lot of compensatory use of them. So, we worry that people would over smoke them to the point that they would be less effective. And that didn't really seem to be true in the studies that were published. That was sort of promising. I think the biggest drawback is that people don't comply with them. So if you can still get regular high nicotine cigarettes, even in the studies, compliance was somewhat low. So if you have a market where people can choose, they're going to choose the higher nicotine products. And I think something that's complicated the issue then, of course, is e-cigarettes. So if e-cigarettes are out there, are people going to really choose very low nicotine cigarettes? Are they going to have the same impact they would have had in a pre-e-cigarette world? It's not clear.
Okay. And then related to that, there's a question, does the UK have tighter e-cigarette policies regulating how much nicotine can be added to e-liquid compared to the FDA, which has failed the US youth demographic?
I'm not an expert on that. In fact, people here may know more about this than I do. My sense is that they do. I mean, certainly the number and type of products which are available are quite limited and controlled. So it's not just an open market where anything is sold. There's only a few products that are actually sold, and they are regulated by the government. So my sense that is one of the aspects of regulation is nicotine content, although I don't know the exact numbers.
All right, and we have time for maybe one or two more questions. This individual asks, she said, we've received feedback at the state level from several of our SUD residential facilities about clients turning down treatment after finding out the facility has tobacco-free grounds, and the client wouldn't be allowed to smoke or use tobacco while in treatment for 28 or more days. Do you have any suggestions on what providers can do to help address this?
So we certainly never want to deter people from getting treatment, and substance abuse treatment, of course. So that's always concerning and problematic, and really is the reason then to have statewide policy. So statewide policy is the solution, because if all the treatment programs have sort of the same standard, and sort of what we call an equal playing field, then you wouldn't have issues like that. And studies have shown that when regions or states implement these kinds of policies, that admissions do not go down. So it's not true that no one will come to treatment. But of course, if you can go across town, people are going to vote with their feet in terms of going to a place where they can continue to use tobacco. So this is really the place for regional or statewide policy where there's one standard that everyone has, and really raises the level and quality of care, in my opinion, because we should all be tobacco-free grounds at this point.
Great. So thank you. Thank you. I think we are out of time right now. I want to thank all of you for attending this webinar, and I particularly want to thank Dr. Williams for all the fascinating information that she's provided us in this presentation. So, and we will follow up with those of you if we got some more questions that are just rolling in right now. So thank you all, and good afternoon.
Thank you.